last lecture, female reproductive system. It's tough. You'll probably need to pause this, take breaks, rewatch it, okay? Put in the time, memorize everything so you can finish very well. Okay, so what's our study tip today? Our study tip is remember your success. You're so close to being done. Over the past 4 months, what has worked for you? Remember your techniques. Remember all the study tips I've given throughout the semester and really utilize the ones that work best for you. Okay. Also, then you can use all this information and take it with you for your next science course, right? You'll probably be taking microbiology next. If this is your last class, then you'll be transferring into your program and you'll be taking more classes there. So everything we've learned, both study tips, analytical skills, and the content itself, all of it's going to help you. Okay. So you should already know all these parts. I'm not going to go over it. I'm going to dive right into, we're going to talk about oogenesis. We're going to talk about the ovarian cycle. We're going to talk about the uterine cycle, and we'll end with menopause. Okay, so oogenesis starts out the same as male, where you start with your your cell that will go through mitosis, and so it has 46 chromosomes with sister chromatids. Okay, and then that division then gives rise to primary oocytes, which also have 46 with sister chromatids, but these are the primary oocytes are the cells that are going to go through meiotic division or meiosis. Okay, so this all happens before birth. Okay, so all the oogonium that a female has will undergo mitosis. That's the germ cell. Okay, so right here. Then those will result in your primary oocyte. Okay, so mitosis is the first step to make identical copies. So you have tons and tons of these oogonium, and then once mitosis is complete, then they can start going through meiosis. So the primary oocyte goes through meiosis, and so it has the same identical amount of DNA as the oogonium. Okay. Now, at the end of the first meiotic division, okay, you will have 23 chromosomes, and sister chromatids are still attached. And this is where it gets weird, okay? So instead of dividing into 2 equal cells like you see for spermagenesis, you will have one really big cell that gets the majority of the cytoplasm and all the resources of the cell. And then you get this tiny second cell, which has the other set of chromosomes, right? But it's not going to continue with meiosis. It's going to degenerate and die. Okay, but this has helped accomplish the goal of making a big cell with 23 chromosomes. Okay, and then meiosis is arrested at metaphase 2 and waits. So you'll have all of these primary oocytes sitting and waiting in the ovary at birth, and then at puberty you'll have one or a few become secondary oocytes, and one typically will win, and then that'll be arrested at metaphase 2, and then that's when ovulation occurs. Okay, So then ovulation, you have about 24 hours, right? So this secondary oocyte will be in the fallopian tube waiting to be fertilized. If it does not get fertilized, it'll degenerate and die. If it does get fertilized, then the second meiotic division completes. You get rid of a second polar body, and then the nucleus of the ovum will combine with the nucleus of the sperm and form a zygote. So female, it's very tricky. It's very different than male. And a lot of that's because there's going to be rapid cell division once the zygote is formed, and you need to have a lot of resources to be able to do that. The sperm have a hard job to get all the way to the female secondary oocyte, right? They have to travel through the harsh environment, right? Make this difficult journey, then burrow all the way through the layers, right? So this is a lot of work. So they need to be small, and only, right? Their only concern is to get their DNA into this secondary oocyte, correct? The oocyte's job, once that is done, is to then take over and do all the work of making a fetus, right? So that's why you get this first and second polar body, which is just the function of that is to get rid of the extra DNA, right? Because before the sperm can combine with the female oocyte, the female needs to reduce down to 23 chromosomes without sister chromatids, just like the sperm, okay? Then they can fuse together and make the zygote, okay? So one more time, before ovulation, you have a secondary oocyte that has 23 chromosomes, each with a sister chromatid. So you could cross out the plus sign and put each. Then after ovulation, you're still arrested at metaphase 2. It's only if fertilization happens that the oocyte completes meiosis and gets rid of those sister chromatids. If that does happen, if you do have fertilization, you complete the meiotic division, you make that second polar body. It degenerates. Why? Because you needed to get rid of those sister chromatids. Okay? So I know it's weird. At the end, if fertilization happens, you get a zygote that will have 46 chromosomes, 23 from mom, 23 from dad. Okay? None of them have sister chromatids at that time. Okay? All right, so I know it's tricky, so let's get some better visuals. Let's watch this video.
Oogenesis is the process by which the female gametes, or ova, are created. The female gamete is called an ovum. Sometimes people will refer to female gametes as eggs, but the term egg can include more than one stage of development, and the definition of an egg also changes depending on the type of organism. For example, the entire prenatal development of birds occurs inside an egg, but in placental mammals, after the egg is fertilized and starts dividing, nobody calls it an egg anymore. So, we're going to use the more precise term for a female gamete, which is ovum, or ova for the plural form. Now you may recall, each ovum must be haploid and contain only one copy of each chromosome. You may also remember that in order to create haploid gametes, a cell must go through the process of meiosis, which involves replicating its genome and then dividing, not once, but twice. In theory, this would create 4 haploid gametes from a single diploid cell, like it does during spermatogenesis. However, this isn't the case for human female gametes. Let's go through the process of oogenesis to see how this works and how many haploid gametes are made from a diploid cell. The diploid germ cells that have the potential to develop into ova are called oogonia. In humans, all of a female's oogonia that she will make in her lifetime are created when she's still a fetus and hasn't even been born yet. In fact, about 1 or 2 months before a baby girl is born, most of her approximately 7 million oogonia die, and the remaining surviving oogonia enter meiosis I and become primary oocytes. These primary oocytes press the pause button on their development in prophase I, after they've replicated their genomes, but before they've made the first meiotic division. They stay arrested at this stage of development for over a decade until the girl begins her first menstrual cycle. Then, for about the next 30 to 45 years, on a monthly basis, primary oocytes resume meiosis where they left off and complete the first meiotic division. When the primary oocyte does finally complete its first meiotic division, it divides the chromosomes evenly, just as you would expect. However, it does not divide its cytoplasm equally. Almost all of the cytoplasm remains in one of the 2 daughter cells, which becomes a secondary oocyte. The other daughter cell, which gets half of the chromosomes but very little cytoplasm, is called a polar body. The polar body is not a functional oocyte. Instead, it degenerates and dies. The formation of a polar body allows the primary oocyte to reduce its genome by half and conserve most of its cytoplasm in the secondary oocyte. The secondary oocyte still has 2 copies of each chromosome, so if it's going to become a fully functional ovum, it must undergo the second meiotic division. This division is also uneven like the first one, with half of the chromosomes going to another very small degenerate polar body, and half of the chromosomes being retained by the ovum, along with almost all of the cytoplasm. In this way, the ovum achieves its haploid state while conserving as much cytoplasm as possible. In humans, oocyte development occurs in the ovaries. Each oocyte is surrounded by a number of follicle cells to create a follicle. When the menstrual cycle begins, one or maybe even a few primary oocytes begin to grow larger, and the follicle cells increase in number and cause the follicle to grow larger too. Usually, some of the developing oocytes will degenerate and only leave one follicle that will mature, but every once in a while, 2 or even more follicles will mature. In these cases, fraternal twins or triplets that are genetically distinct may be born. In any case, as a follicle reaches maturity, the primary oocyte completes its first meiotic division and becomes a secondary oocyte. Very soon after that, the follicle ruptures and the secondary oocyte is released into the fallopian or uterine tube, even though the second meiotic division hasn't occurred yet. The release of a secondary oocyte from the ovaries is called ovulation. Once released from the ovary, the oocyte slowly travels down the fallopian tube toward the uterus. Fertilization usually occurs in the part of the fallopian tube nearest the ovary. This is because the oocyte is only viable for up to 24 hours after ovulation. If it isn't fertilized by a sperm within this time period, then the oocyte never completes the second meiotic division, and so it never technically becomes an ovum. However, if the secondary oocyte is fertilized by a sperm, it immediately finishes its second meiotic division, releases a polar body to leave only a haploid female genome in the ovum, and then becomes a zygote as the nuclei of the sperm and egg fuse together. In summary, oogenesis is the process by which the female gametes, or ova, are created. The female gamete is called an ovum. The diploid germ cells that have the potential to develop into ova are called oogonia. In humans, all of a female's oogonia that she will make in her lifetime are created when she's still a fetus and hasn't even been born yet. By the time a baby girl is born, all of her oogonia have either entered meiosis I and become primary oocytes or degenerated and died. The primary oocytes press the pause button on their development in prophase 1 after they've replicated their genomes, but before they've made the first meiotic division. In humans, oocyte development occurs in the ovaries. Each oocyte is surrounded by a number of follicle cells to create a follicle. When the menstrual cycle begins, one or maybe even a few primary oocytes begin to grow larger, and the follicle cells increase in number and cause the follicle to grow larger too. Usually, only one follicle reaches maturity, and the primary oocyte in the follicle completes its first meiotic division and becomes a secondary oocyte. Very soon after that, the follicle ruptures, and the secondary oocyte is released into the fallopian or uterine tube before the second meiotic division has occurred. The release of a secondary oocyte from the ovaries is called ovulation. Once released from the ovary, the oocyte slowly travels down the fallopian tube toward the uterus. If the secondary oocyte is fertilized by a sperm, it immediately finishes its second meiotic division, releases a polar body to leave only a haploid female genome in the ovum, and then becomes a zygote as the nuclei of the sperm and ovum fuse together.
Did you know that this video is a part of a free course that
Oogenesis, production of ova. So before birth, as you saw in the video and as I mentioned already, the oogonium begin meiosis and become primary oocytes. Then they stop in prophase 1 of meiosis. After puberty, several become active, but usually only one will finish meiosis 1. And then primary oocyte goes through meiosis 1. And this is the first unequal division. So you have the small polar body and it degenerates, and then you have the large, the other one is large, has the secondary oocyte, and each with sister chromatids is what it was supposed to say. It looks like it got cut off. But all of the oocytes that go through maturation and ovulation will have this first division and get rid of the polar body. Okay, only those that get fertilized will go through the second. Okay, so both of the cells did begin meiosis 2, but that polar body doesn't finish and it degenerates. The secondary oocyte that remains, which is very large, it gets paused in metaphase 2, and that's when you would ovulate, right? So the mature follicle, secondary oocyte paused in metaphase 2 is ovulated and it waits to be fertilized, otherwise it will degenerate. Okay, so when you're the primary oocyte, you still have your sister chromatids, okay? And even when you're a secondary oocyte, you still have your sister chromatids. It's not until you complete meiosis 2 that you get rid of that, okay? All right, so in conclusion, one functional gamete is what you get, right? So usually when you go through meiosis, you say, okay, one cell divides into 2, then it divides into 4. And that is the case for spermatogenesis. But for oogenesis, because we have that polar body, you actually just keep with one cell that keeps developing into the ovum, okay? So If you complete oogenesis, then you end up with one functional gamete called an ovum. It is large. It contains most of the cytoplasm from the original cell. Okay, the two polar bodies have degenerated. Their purpose was just to get rid of the extra genetic material. As soon as the ovum completes meiosis 2, it combines with the sperm's DNA and forms a zygote. If there was no fertilization, then you never actually had an ovum, you just had a secondary oocyte, and it will degenerate. And then you'll have menstruation in a week or two. Okay, so looking at a 28-day cycle, we're going to talk about the ovarian cycle, which we've kind of already been talking about a little bit. So you have your primary follicle, and actually you have lots and lots and lots of them. They're not all shown here, but the majority of this ovary would be full of primary follicles that you're born with. Okay, then at puberty, a couple will start to grow. Okay, and so now you have a primary oocyte, but it's referred to as a secondary follicle because it's been growing. Okay, now I do have these steps typed on the next set of slides, so don't worry. Okay, when you get to the mature follicle, you'll notice it has this shape here. This is called an antrum. It's fluid filled. You also have some really important structure here, which we'll also talk about, and I have a short video. This is a mature follicle, and it contains a primary oocyte. Before ovulation, the oocyte will be a secondary oocyte, and then it will burst and release. Okay, the follicle will burst and release the secondary oocyte. Okay, and then that tissue that gets left behind, it develops into what we call the corpus luteum, and luteum means yellow. Okay, and of course corpus, corpse, or tissue, decaying tissue. And so the corpus luteum plays a very important role in releasing hormones, which we'll talk about in the second half of this lecture. And then you have, after a certain amount of time, if no pregnancy, you'll get the corpus albicans, which is white, and then it will break down further and be gone. But when you have the corpus albicans, it's no longer doing any function. There's no hormones. Okay, and that's the whole cycle. Okay, so let's look at those steps. Ovarian cycle is divided into 3 phases: the follicular, ovulation, and luteal. Okay, so the first 1 to 13 days is the time it takes for that follicle to mature and reach the point of ovulation. Okay, so a follicle is an oocyte plus the layers of cells that surround it. So you have your primary follicle. It has a primary oocyte. It also has granulosa cells, and those, as this follicle develops and grows, those granulosa cells enlarge and they form multiple layers around the oocyte. Then you also get your zona pellucida forming, right? And so that's the layer of glycoproteins. Then as it matures more, it's called a secondary follicle. So you still have your primary oocyte, but now all the tissues around it have developed more, and then you develop this extra tissue called thecal cells. And this, we'll see in a video, has like 2 types of layers. And as we'll see later on. Each of these layers plays a very important role with hormone regulation and fertilization, even, right? So you have fluid-filled vesicles that form during the secondary follicle as well. And when those fluid-filled vesicles enlarge into a single vesicle, it's called an antrum, and that's the characteristic appearance of a mature follicle. Most importantly, what's happened and what makes this a mature follicle is that now you have a secondary oocyte. So you completed your first you completed meiosis 1, you've begun meiosis 2, and then you pause in metaphase 2. Okay, so when you pause in metaphase 2, you have 23 chromosomes. So you've accomplished the reduction from 2N to 1N, but you still have those sister chromatids. So if you're going to, if you get fertilized, then you're going to have to get rid of those sister chromatids. Okay, so at this point, you have a mature follicle that contains a secondary oocyte. Any other follicles that may have started the growth, they will degenerate so that you only have one mature follicle that remains. This degeneration is also called atresia. Now, occasionally, and for some people more often than others, you could have 2 or even 3 follicles remain as mature follicles, and that is how you would end up with the possibility of having twins or triplets that are not identical. Okay, now we just talked about the steps and development of the follicle, and it's really important that you remember the difference between a primary and a secondary follicle, and the difference between your primary and your secondary oocyte. So you have a secondary follicle, but you still have a primary oocyte until you get all the way to a mature follicle, and then you have your secondary oocyte, and the secondary oocyte will then be pushed out of the ovary very forcefully. You get this rupture of the follicle, right? Okay, so that's as far as we've gotten in our talk so far. Now we'll see the rest of this cycle. Okay, so that was ovulation, the big burst. It's a day 14, it's just a single day. Okay, mature follicle ruptures, releases the secondary oocyte out of the ovary. That's going to be taken up by the fallopian tube and slowly travel to the uterus. And so you have only about 24 hours to fertilize it. Once it gets close to the uterus, it starts to break down. Okay, and so you would not be able to fertilize it anymore. Interestingly, okay, so we say you only have 24 hours to fertilize it. The secondary oocyte only has 24 hours before it breaks down. But spermatozoa, more correctly, they can survive up to 3 days. So it is possible that if you've had sex, a day or even 3 days before ovulation, that you could get fertilization. Okay. Luteal phase. This is day 15 to 23. Formation of corpus luteum, as I mentioned already in that picture, the follicle cells that are left behind after you ovulate the secondary oocyte, all that tissue that's left behind, which we'll talk about even more when we get to all the hormones, it's going to fill with lipids. It's going to turn into the corpus luteum, and its main role is to maintain the endometrium of the uterus to be thick and ready for implantation in pregnancy. Okay. If no pregnancy, then the corpus luteum will degenerate and become scar tissue called corpus albicans, which slowly breaks down over time as well. If you do become pregnant, if there was fertilization, then it implants into the endometrium, right? And then the corpus luteum actually will persist for 8 to 12 weeks. And it's super important that it persists because it produces hormones that you need to maintain the thick endometrium. If the corpus luteum degenerates too quickly, then your endometrium layer will be lost and you'll have a miscarriage. Okay, one more short video on maturation of the follicle and oocyte.
A primordial follicle consists of an oocyte surrounded by a single layer of squamous granulosa cells. A primordial follicle becomes a primary follicle as the granulosa cells become enlarged and cuboidal. The primary follicle enlarges and the granulosa cells form more than one layer. The zona pellucida forms around the oocyte. The structure is called a secondary follicle when fluid-filled vesicles develop among the granulosa cells and a well-developed capsule, or theca, becomes apparent around the granulosa cells. The theca possesses internal and external layers. The structure is called a mature follicle when the fluid-filled vesicles form a single antrum. At full maturity, the oocyte is located in the cumulus mass. During ovulation, the oocyte is released from the follicle, along with some surrounding granulosa cells of the cumulus mass, called the corona radiata. Following ovulation, the granulosa cells divide rapidly and enlarge to form the yellow corpus luteum. When the corpus luteum degenerates, it forms the white corpus albicans.
Okay.
A primordial
Hormones. Just like the male, you have the hypothalamus that releases gonadotropin releasing hormone that stimulates the anterior pituitary to make LH and FSH. Then that will signal the release of estrogen. Estrogens are made by granulosa cells of the ovarian follicles. Small amount of estrogen made by the corpus luteum. Low levels, okay, and this is weird and tricky, so pay attention. Low levels of estrogen actually inhibit FSH and LH release. It's not until you build up high levels of estrogen, okay, so during and right before ovulation, when your follicle gets to be mature, you start releasing high levels of estrogen. That high level of estrogen then stimulates FSH and LH release, and you'll see an FSH and LH spike, and then that's how you get ovulation. Okay, hormones continued. So progesterone is another hormone, and this is produced after ovulation by the corpus luteum. It signals growth, thickening of the endometrium in the uterus. If no pregnancy, the corpus luteum degenerates, and then your levels of progesterone are going to drop. This signals menstruation or menses, okay? So what's the purpose of menstruation? It's to remove the top endometrium layers and get ready for this whole process again. So the whole point of all of this is to have an environment that is ready to grow a baby, right? So the whole process, the whole cycle, female reproductive cycle, is to make the environment where you can have fertilization, implantation, and growth and development for a baby. Okay. And as I mentioned already, the most common causes of miscarriage is when that endometrium layer gets removed, due to insufficient levels of progesterone. So if your corpus luteum doesn't persist for the 8 to 12 weeks, you will have a drop in progesterone. You'll lose your endometrium layer, right? You'll have a period, you'll have a miscarriage. Okay, cuteness, time for cuteness. Aren't these babies adorable? Okay, so most triplets born today are the result of infertility treatments. One commonly used drug is called Clomid. It stimulates the pituitary into producing more follicle-stimulating hormone, FSH, and luteinizing hormone, LH. So I want you to explain how Clomid produces triplet pregnancies. Why? Why is it more common to have triplets when you're on fertility treatment? Do you think that these triplets would be fraternal or identical? And then lastly, what might the dangers of being pregnant with triplets? So how would it be dangerous to the mother? How would it be dangerous to the triplets? Okay, pause the video. Okay, so I trust that you took time to answer these questions. Clomid stimulates the pituitary to release LH and FSH. And so what's that going to signal the body to do? To mature more oocytes. So if you mature more oocytes, you're more likely to end up with multiple oocytes being released during ovulation. And if that happens and fertilization happens, then you can have different sperm fertilize each of the eggs get fertilized by its own sperm. So that would be fraternal, right? They're not going to be identical because they had their own egg and own sperm, so they're all unique, okay? But of course they're siblings, so they'll still have some similarity. Okay. What else? It also turns out that in certain families and even certain ethnicities that twins and or triplets are more common. It also turns out that the older the mother is, it is more likely for this to happen as well. So that's interesting. All right, so dangers. It's not easy to grow a baby, so imagine 2 or 3. That's going to be a lot of extra weight. It's going to be a lot of extra blood supply. The mother could have preeclampsia, which is dangerously high blood pressure. That puts the mother at risk, but it also puts a higher risk of miscarriage as well, right? Also, because of all this demand on the mother's body and the limited space, twins and triplets tend to be premature, meaning they're born before the full term of the pregnancy, and so they might be very small, underweight, and if there's depending on how small they are, how underweight they are, they could have a lot of health problems or even not survive and die. Okay, so the typical term for a pregnancy is 40 weeks. Now, a lot of mothers never make it to 40 weeks, even with just one baby. It's pretty common anywhere after 35 weeks, right? So the goal for triplets is just to make it to the 28-week mark. But as you can guess, that's drastically shorter than 40 weeks. So those babies are going to be small. They are going to be not necessarily underweight, but low weight compared to a pregnancy with one child, right? So it is tough. It's really tough. If you are fascinated by triplets, you can talk to Dr. Hayes. She has raised triplets. Her triplets are graduating high school this year. Okay, so ovarian cycle, week 1. Follicle growth. Estrogen is low because you don't have very many granulosa cells yet. As those granulosa cells grow, they'll produce more. Okay, so during follicle growth, estrogen levels are low. Low estrogen, remember, is the negative feedback for LH and FSH. So your LH and FSH levels are low. Your progesterone levels are also going to be low because you don't have a corpus luteum at this time. Week 2, growing follicle makes more estrogen, and at day 13, the estrogen levels max out. The high estrogen then turns LH and FSH on, and you get a spike or surge at day 14, which is the trigger for ovulation. Remember, ovulation releases a secondary oocyte into the fallopian tube. It's arrested at metaphase 2 and it awaits fertilization. Again, your progesterone levels are low because you do not have a corpus luteum quite yet. Week 3, estrogen levels are going to drop. Your LH and FSH levels are going to decrease. The follicle, the leftover tissue, is going to develop into the corpus luteum, so then your progesterone levels are going to increase. This also does make some estrogen. All right, week 4. If no pregnancy, the corpus luteum degenerates. Estrogen and progesterone levels decrease. If pregnant, then you will suddenly make human, the HCG, the human chorionic gonadotropin hormone. This is typically what's tested for on a pregnancy test, especially if you go and get a blood test. This is specifically what they test for. It's always best to get the blood test to confirm pregnancy. Urine strips have come a long way, but there are still a lot of factors that can make them not accurate. So just make an appointment and get that blood test. Okay. Now, this HCG hormone is released from the embryo, but it's not until around 8 to 12 weeks that it's going to produce enough of the hormone to sustain your endometrium. But in the meanwhile, as those levels are growing, the HCG sustains the corpus luteum. So this is why your corpus luteum doesn't degenerate, but persists for 8 to 12 weeks. So during this time, as HCG is being released from the embryo and the corpus luteum is doing the production of progesterone to keep the endometrium layer, the embryo will also start to make progesterone. And so the idea here is that you need the embryo to take over progesterone production so that when the corpus luteum does degenerate, your endometrium layer is still thick because the embryo is releasing progesterone. So if the corpus luteum decreases before the embryo makes enough progesterone, then you're going to have a miscarriage. So this is why most miscarriages occur around the 3rd month when the corpus luteum degenerates. Okay? So one more time. HCG is released from the embryo. Its role is to maintain the corpus luteum for 8 to 12 weeks. During that time, the embryo is going to start producing progesterone. It needs to be able to get up to a high enough level to take over for the corpus luteum. If the corpus luteum decays before the embryo makes enough progesterone, then your endometrium layer is going not to be able to remain thick. It's going to be lost and you'll have a miscarriage. And that's around the 3rd month. So this is why physicians usually advise women not to share their good news of being pregnant with everybody, maybe just their closest friend, closest family member, right? And wait until they get past the 3rd month mark and then share it with everybody, just because miscarriages are very common. Okay, it's not talked about enough in society, and there's unfortunately a lot of stigma. A lot of women suffer a lot of worry and guilt that they did something wrong or there's something wrong with them. Actually, it's completely normal and super common to have miscarriages. Miscarriages happen so frequently. Most women actually don't even know they're pregnant, don't even know that they had a miscarriage. And then, like I said, if you do find out that you're pregnant, wait until you get past that 3rd month mark, because this is difficult. There's a lot of coordination that has to take place. And there's nothing that a female can do to increase this or decrease the risk, okay? You take care of yourself, you try to maintain your stress, but ultimately it's not in your control, okay? So if this does happen to you, or if it has happened to you, please do not feel guilty, do not feel shame, do not blame yourself, okay? Happens to the majority of women. Okay, next. Progesterone has to remain high throughout the pregnancy to maintain the endometrium layer. So here is this chart, this graph. What happened to my mouse? Here we go. It starts at, it says 15 to 0 to 15, and that's a little weird, but it's because they're looking at before and after ovulation. Okay, so really this would be 0, day 14, and 28, okay? But the purpose of this is just to compare your hormone levels before and after ovulation. The dotted line represents 0, which represents ovulation. So it's actually day 14, right, of the entire cycle. All right, so let's start. You start out with low levels of LH, low levels of FSH, very low levels of progesterone. Why? Because you haven't ovulated yet. Okay, so during this time, you have your estrogen levels and you have a developing follicle. And as that follicle matures, once it becomes a mature follicle, now you have a lot of granulosa cells and they release more and more estrogen, and you get this peak. And notice this is like the day before ovulation. You get the peak in estrogen, or really the correct term is estradiol. Okay, but we know it as estrogen in slang. That correlates with your FSH and your LH spike the next day, right? So this peak in estradiol the day before ovulation is the trigger to turn on FSH and LH release. It grows rapidly to high numbers or high concentration, and we call that the surge or the peak. And then that triggers ovulation. Then when you ovulate, of course, now your granulosa cells are, part of them are left behind and develop into the corpus luteum. Some of them remain with the secondary oocyte. In either case, you get a drop off of estrogen, right? Almost to the low levels that we started with, but not quite. As your corpus luteum develops, it starts to release progesterone, which you see here. It also releases some estrogen, which is why it goes back up, okay? And the purpose of the progesterone, remember, is to keep the endometrium thick in case fertilization happened and you implant. If that happens, then you will maintain the corpus luteum and keep those levels high. But if fertilization didn't occur, then the corpus luteum turns into the corpus albicans, and your levels of progesterone drop off. And same thing with your estrogen. Okay? I know, that's a lot. I warned you. All right, so another way to look at this is to compare the ovarian cycle and the uterine cycle, which they call the menstrual cycle. Okay, so this down here at the bottom is the endometrial layer. So the endometrium. The red on top is blood, so this represents menstruation, shedding of those top layers, and going back to a thin layer of endometrium. And then as your estrogen levels rise, it starts to thicken, and then when you release progesterone, it gets to the thickest point and stays. So as long as you have progesterone, the thickest part, right, of your endometrium will remain. But when your progesterone levels drop off, then your endometrium layer will also start to thin out, and then you'll shed it. And so this is the start of menstruation again. Okay, so what controls your progesterone levels? Again, is having your corpus luteum. How do you get your corpus luteum? From ovulation, right? How do you get ovulation? From having a spike in LH and FSH. How do you get that spike? From your estrogen level spiking. How does that happen? Your mature follicle, right? So spent all this time moving forward, and now we just went kind of backwards. So know it. Left, right, up, down, forward, backwards. Okay. So what are the 3 phases of the uterine cycle? Your first, 1 to 5 days, and of course some women longer, and that's normal. But based on a 28-day cycle, we say the first 1 to 5 days is your menstruation. The endometrium layer is removed, blood vessels are exposed, and you bleed, and you wash it all away. Then you have the proliferative phase, days 6 to 14. This is when your estrogen levels stimulate the growth of the endometrium. It gets thick again. You get more vessels, right? And then you have your secretory phase, days 15 to 28. Even more growth of the endometrium due to progesterone, right? So after you've ovulated and you've made the corpus luteum, then you get your progesterone and you get even thicker. And if you do not become pregnant then your progesterone levels drop, and then you start menstruation again. You get rid of all that endometrium. Okay? But if you are pregnant, then your progesterone stays high and you keep your endometrium intact. All right, so we've made it pretty much to the end. Let's watch this video, which will show you the ovarian and uterine cycles, and then we will finish off with menopause. Okay.
Consists of a sequence of changes that occur in the ovaries and uterus. During each reproductive cycle, gonadotropin-releasing hormone, or GnRH, from the hypothalamus stimulates the anterior pituitary to release 2 gonadotropic hormones, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. The target organ for these 2 hormones is the ovary. Each female reproductive cycle has 2 components, the ovarian cycle and the uterine cycle. Ovulation occurs on day 14 of the 28-day ovarian cycle. The 14 days prior to ovulation are known as the follicular phase, while the 14 days following ovulation constitute the luteal phase. The ovarian cycle is regulated by changing levels of FSH and LH. Ovulation occurs on day 14 of the 28-day uterine cycle. The 14 days prior to ovulation are subdivided into a menstrual phase, days 1 to 5, and a proliferative phase, days 6 to 14. The 14 days after ovulation constitute the secretory phase. The uterine cycle is controlled by the ovarian hormones, estrogen, and progesterone. The events in the ovary prior to ovulation constitute the follicular phase of the ovarian cycle. In the first 5 days, increased GnRH stimulates the anterior pituitary to increase production of FSH and LH. This stimulates primordial follicles in the ovary to mature into primary follicles, each containing a diploid primary oocyte that is arrested in prophase 1 of meiosis 1. At the same time in the uterine cycle, decreasing levels of progesterone lead to sloughing or shedding of the endometrial lining. This is the menstrual phase, commonly referred to as a woman's period. In the ovary during the second part of the follicular phase, days 6 to 13, a small number of primary follicles form secondary follicles. About 2 days before ovulation, under the influence of increasing levels of LH and FSH, the follicle expands to form a swelling on the surface of the ovary. Approximately 16 hours before ovulation, the levels of FSH and LH surge to cause the final maturation of the follicle, now called a mature or Graafian follicle. Just prior to ovulation, the primary oocyte completes meiosis 1 to form a haploid secondary oocyte. Simultaneously, the lining of the endometrium begins to reform under the influence of estrogen produced by the ovarian follicular cells. This is known as the proliferative phase of the uterine cycle. As the level of LH peaks, proteolytic enzymes produced in the follicle cause its wall to weaken and rupture. Ovulation is the release of the secondary oocyte from the mature follicle. After ovulation, the ovary enters the luteal phase of the ovarian cycle, days 15 to 28. During this period, the remaining ovarian follicular cells form a corpus luteum, which produces the hormones progesterone and estrogen. Progesterone and estrogen from the corpus luteum stimulate further thickening of the endometrium in the secretory phase of the uterine cycle, days 15 to 28. If fertilization and implantation occur, cells at the implantation site in the uterus begin to produce human chorionic gonadotropin, or HCG. HCG prevents degeneration of the corpus luteum, so that elevated progesterone and estrogen levels are maintained to prevent shedding of the uterine lining at the end of the uterine cycle. After 8 to 12 weeks, the corpus luteum ceases to produce progesterone and estrogen and degenerates to become the corpus albicans. The placenta in the uterus replaces the corpus luteum in producing progesterone and estrogen. If fertilization does not occur, the corpus luteum becomes a corpus albicans by the end of the cycle. This leads to decreased levels of progesterone and estrogen and results in menstruation and the beginning of the next uterine cycle.
Okay. All right, so time for a slight break, perhaps. Birth control. The pill, right? Birth control pills or Depo-Provera shots or even IUDs, intrauterine devices. They can all have hormones that prevent ovulation. Okay, so you can have so the pill. Let's start with the pill. Usually has estrogen and progesterone. So that your levels don't fluctuate and then you don't ovulate. You take a pill every single day. It will have reminder pills or little iron pills during the time that you have your menstruation. It's also common that a lot of females won't even have a period, or it'll be very short and very light when on the pill, depending on the person and the type of pill, the strength, etc. Okay. Depo-Provera shots are a shot given typically in the arm every 3 months. It has, I believe, a larger dose of progesterone than the pills would give. This is, some people really like this. Some women prefer not to have to think about taking a pill every day and just going in every 3 months and getting a shot. Other women have had a lot of side effects, negative side effects, particularly weight gain and acne. So, not everything works for everyone in the same way. The Mirena IUD has hormones that slowly are released. I don't recall for how many years that will last. If you do an IUD without hormones, it would be copper is the best. There are some plastic ones as well, and they can last a very long time. They don't have any hormones, so you'll still go through all the regular, your hormone levels can fluctuate, but you would not be able to implant. IUDs are interesting. You could definitely Google, find a couple short YouTube videos that explain how they work. It used to be the case that you wouldn't get an IUD unless you had already had a child, but that's not even true anymore. But of course, you would talk to your doctor and figure out what's the best option for you. And even further, there are, I forget what it's called, but you can get the underskin implant that is similar to birth control pills, slowly releasing, but then you don't have a period at all because it's constant. I forget what that's called, but it's a little implant under the skin. And then of course there's the ring, which is a vaginal ring, which slowly releases hormones as well. So a lot of different birth control options, right? But again, the idea is to keep your estrogen levels constant so you don't ovulate. Okay. Some people use the rhythm method, and so rhythm method and when pregnancy can occur. So this requires you to know a lot, understand a lot, really track your body, be very, very careful. But it can work for people who are very in tune with their body, very, very careful. Okay, so how long does an ovum live, or really secondary oocyte? 24 hours. So you would know a spermatozoa can live for 3 days. So if you're not using condoms, then you would need to not have intercourse for 3 days before ovulation, right? And 1 day after. So ovulation is supposed to be 2 weeks. It's always 2 weeks before your period, but women don't always have a 28-day cycle. So you would need to really know your cycle. Your basal body temperature is about 0.5 degree higher during ovulation. So you could be tracking that. You could also be tracking like mucus, thickness, things like that. Okay. Okay. Another thing when we're talking about female reproduction is, like I said, not all women are on a 28-day cycle, and not all women have regular cycles either. So some women have, they'll have a really long period, like maybe they bleed for 2 weeks, but then they don't have one the following month, right? There's all sorts of different patterns and irregularities. That's another benefit of being on birth control, is it should make all that regular for you. Of course, there's risks with birth control, risk of a stroke. So if you are a smoker, you shouldn't be on birth control. If you're over 35, then that also is another risk factor. Okay, moving on. Menopause. Menopause is another topic that doesn't get spoken about often or enough. Okay, so about 1 to 2 years before menopause is called perimenopause. You will have irregularity of your estrogen, progesterone, and that can lead to a lot of symptoms like hot flashes, mood changes. Once you've had a whole year of no period, then you're considered to be in menopause. This process usually is around age 50. Okay. And at this point, when you start perimenopause, your follicles are not responding to FSH and LH, which is why you get all this irregular levels of hormones. Once you enter menopause, then you have absolutely no remaining follicles that will respond to FSH and LH. And so then you'll have no more ovarian cycle, and you are non-fertile. You're not able to get pregnant. Osteoporosis and heart attack are the most important, or you're at risk. Your risk of osteoporosis and your risk of heart disease increase when you go through menopause. And this is because estrogen plays a very important role in strong bones, right? Healthy bones, and also your vascular system. Okay, so at birth, there are approximately 1 million eggs, which we shouldn't be calling eggs, right? Oocytes. And by the time of puberty, you have about 300,000. And then of that, only 300 to 400 actually will be ovulated throughout the woman's reproductive lifetime. And fertility can drop as a woman ages due to the decreasing number and the quality of these remaining oocytes. Okay, so I do have a little video to show you for menopause, and then just a couple reminders, and then that's it. Okay, so sit back. This is going to go through a little bit of review, and then it will get to the menopause part. All right.
Today, in females, the reproductive period or fertility period refers to the years of monthly menstrual cycles between the first menstrual period, which happens at puberty, and then the permanent stopping of menstrual cycles, which is called menopause. Menopause usually sets in around age 50, and it's preceded by a couple of years of hormonal and physical changes, and this is called perimenopause. To be more specific, a woman has entered menopause when an entire year has passed since her last menstrual period. During the reproductive period, the ovaries have basically got a ton of ovarian follicles scattered inside them, and each ovarian follicle is made up of a ring of granulosa and theca cells surrounding a primary oocyte at the core. And during each menstrual cycle, one of these follicles ruptures at ovulation, and it releases the oocyte out into the fallopian tube, where it can be fertilized by a sperm. Or it can just carry down on its path and you don't get pregnant. So the weird thing is, even though females are born with millions of follicles, only about 400 of them are actually mature enough to release their oocyte throughout the lifetime. So if you're ever feeling useless, just think of those ones that have gone to waste. Anyway, all of this process is ultimately controlled by the hypothalamus, which is all the way away from the gonads up in the brain. And the hypothalamus secretes gonadotropin-releasing hormone, or GnRH, which travels to the nearby pituitary gland and makes it secrete two hormones of its own, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. FSH and LH then make the ovarian follicles secrete sex hormones. So, the theca cells make androstenedione, a sex hormone precursor, that the granulosa cells convert into estradiol, a member of the estrogen family, and progesterone. The menstrual cycle, on average, lasts about 28 days, and for the first 2 weeks, which are called the follicular phase, the granulosa cells make more estrogen and send a negative feedback signal to the pituitary, which inhibits the production of FSH. Likewise, progesterone inhibits LH production during the second half of the menstrual cycle, so hormone levels are constantly regulated, and this leads to a cyclic and predictable pattern in hormone secretion during the reproductive period. During each menstrual cycle, a couple of follicles are stimulated by FSH and LH, until one of them emerges as a dominant follicle and ruptures at ovulation. And the rest of them, well, it's pretty bleak, really. They just degenerate off and die. Over time, many ovarian follicles degenerate, and the ones that remain become less and less sensitive to FSH and LH. This goes on until menopause, when there are no remaining follicles responding to gonadotropins, and that causes the menstrual cycle to cease entirely. Now, a couple of years before menopause, the woman enters a transition period called perimenopause. And during perimenopause, the ovaries have a lot less functional follicles, so the menstrual cycles preceding menopause are often anovulatory. Anovulatory means without ovulation, and that's because none of the follicles are responsive enough to FSH and LH stimulation in order to mature and release the oocyte at ovulation. The lack of ovulation can cause missed or irregular periods, and they become more irregular and more infrequent as the ovarian follicles start to run out even more. And fewer follicles also means less estrogen and progesterone, so less inhibition on the hypothalamus and the pituitary. And in turn, the hypothalamus and pituitary produce more frequent, larger bursts of GnRH, FSH, and LH. The difference is, though, the pattern of secretion is much more erratic than during the reproductive period. And this erraticness, along with decreasing estrogen levels, can cause a bunch of problems. And these include hot flashes and night sweats, which can lead to trouble sleeping, and also vaginal dryness, which can lead to dyspareunia, which is pain during sex. Also, estrogen normally has a protective effect on both the cardiovascular system, where it helps to keep the blood vessels' walls nice and flexible to accommodate blood flow, as well as the skeleton, where it helps sustain bone density. So, low levels of estrogen can also lead to complications like cardiovascular disease and osteoporosis. So women entering menopause should have their LDL cholesterol levels checked, and if high, dietary changes or medical therapy with statins may be required. Osteoporosis is diagnosed using a dual energy X-ray absorptiometry, or a DXA, test. And screening should start at 65 in the general female population, and 60 in smokers. This test measures bone mineral density at different sites throughout the body, like the lower spine and hips, and results come back as a T-score and a Z-score. A Z-score lower than 2.5 standard deviations at any site confirms osteoporosis. Finally, changes in hormone levels can also impact the mood, so women going through menopause may experience irritability or mood swings. So even though transitioning into menopause is a natural step in the aging of the female reproductive system, these symptoms may have a negative impact on overall well-being. The good news, though, is that the body can adjust to the hormone changes, so they actually go away on their own after a couple of years. But in the meantime, there are tons of ways that we alleviate them. For hot flashes and night sweats, it's really useful to avoid triggers like hot drinks and spicy foods, as well as just maintaining a cool ambient temperature. Additionally, selective serotonin reuptake inhibitors like venlafaxine can help with both hot flashes and psychological symptoms like mood swings and irritability. In some cases, hormone replacement therapy with estrogen can also be used to relieve hot flashes. However, all women with an intact uterus need a progestin in addition to estrogen to prevent endometrial hyperplasia and cancer. Women who have undergone a hysterectomy should not receive a progestin, because its key benefit is prevention of endometrial hyperplasia and carcinoma, and that's no longer relevant. For vaginal dryness, there are things like vaginal estrogen creams and lubricants that can be used during sex to help with pain. And in an attempt to prevent osteoporosis, calcium and vitamin D supplements can be used. If osteoporosis is diagnosed, medical therapy with bisphosphonates should be initiated. Okay, so as a quick recap, menopause refers to the natural halting of the monthly menstrual cycles, and this is because of the depletion of ovarian follicles. It's usually considered that a woman has entered menopause when more than 1 year has passed since her last menstrual period. This usually happens around the age of 50, and is preceded by a couple of years of hormonal changes that may manifest as hot flashes and night sweats, vaginal dryness, as well as mood changes. Avoiding certain foods and maintaining a cool ambient temperature, using vaginal creams and lubricants, as well as certain medications, can help manage the symptoms of menopause.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards today.
All right, so that's the end of our lecture. Remember, this Friday, you have a lot of assignments due. You have your review homework part 1. You turn in questions with answers to me on the assignment, and then you go to the discussion board and put just your questions. Then you guys can start on part 2 once everyone's posted their questions, and you choose which ones you're going to answer, and they have to be different than the ones that you already did yourself. Okay, both labs are due Friday as well. Buffers 8.4 and PhysioX 10. If you downloaded Buffers 8.4 the first day I posted it, make sure you go back and get the updated one. We just changed one data point for the first experiment. And then you have PhysioX 10, which is also due, and your acid-base worksheet. For your acid-base worksheet, make sure you draw the box for every single question, just like I did in lecture and just like I did in the Zoom. So if you're confused, go watch my Zoom from Wednesday, okay? Also make sure you're putting the mechanism for compensation. So how do the lungs compensate? How do the kidneys compensate to raise or lower the pH of the blood? Okay, that is it. Bye.